I'd like to thank the International Laparoscopic Liver Society for allowing me to present today on body mass index and outcomes in laparoscopic liver resection. We've performed a systematic review at the Royal Brisbane and Women's Hospital in Brisbane, Australia. As we all know, the obesity epidemic shows no signs of slowing down. Here in Australia, 2/3 of our adult population are classified as overweight or obese, and this is associated with multiple comorbidities and negative post-operative outcomes. Laparoscopic surgery has been shown to be safe in some procedures for obese patients, but there is limited data in laparoscopic liver surgery. There are a number of possible challenges of a laparoscopic liver resection in an obese patient. There can be increased perceived technical difficulty due to their body habitus and subsequent changes in the liver parenchyma, such as non-alcoholic fatty liver disease and cirrhosis, which have been shown to increase morbidity after open liver resection. The existing studies in the literature that look at BMI and laparoscopic liver resection have mostly been performed in Asian countries, where there is varying definitions of obesity compared to the West. In an Asian population, a BMI of greater than 25 is often defined as obesity, whereas in the West, we use a BMI of greater than 30. The aim of our study was to examine the relationship between BMI and outcomes after laparoscopic liver resection using a systematic review of the existing literature. We performed a systematic search using two key concepts, BMI or obesity and laparoscopic liver surgery. The inclusion criteria were adult patients over the age of 18. We used both benign and malignant pathology and all forms of laparoscopic liver resection. The exclusion criteria included case reports or small series and other surgical approaches, such as robotic liver resection. We extracted data on study characteristics and outcomes separated into three groups: surgical, post-operative, and oncological. Unfortunately, a meta-analysis could not be done due to heterogeneity of methods and data. Here is our Prismaflow diagram of our results. We started off with 1,472 studies, and after abstract screening and selection, there were 7 final studies included. Here is a table of all the included studies. They were all single-center retrospective studies published within the last 5 years, with a total number of 1,661 patients, 481 of these being obese. There was 42% malignant pathology and 25% major hepatectomy. There was variability in how the weight classes were broken up. Some people used non-obese and other people classified non-obese patients into normal and overweight BMI. There's also variability in the definitions of obesity. 4 of the studies performed in Asia used a BMI of greater than 25 to define obesity. 1 study done in China used a BMI of greater than 28, and the remaining 2 studies, which were done in France and the USA, classified obesity as a BMI of greater than 30. With regards to surgical outcomes, 1 study found a BMI greater than 28 to be an independent risk factor for conversion. There was no difference found in any of the studies for length of stay or operative time between obese and non-obese patients. With regards to estimated blood loss and transfusion rate, 1 group of authors found an increased estimated blood loss and transfusion rate between normal and overweight patients, but not the obese patients. Otherwise, there was no other difference found in any other study. There was no difference found in overall mortality between weight groups, and no difference in overall morbidity, except for in 1 study where severely obese patients had a higher morbidity compared to the rest. There was no differences between weight classes for major and minor complication. 1 study found an increased bile leak rate in obese patients, and no difference was found in reoperation rates. No differences were found between obese and non-obese patients with regards to rates of wound infection or intra-abdominal collection. Moving on to oncological outcomes, no differences were found in tumor size or margin size between weight classes. 1 study looked at R0 resection and found that there was a higher R0 resection rate in obese patients. The authors postulated that this would have been because patients who were obese and had smaller tumors or tumors in more favorable positions were chosen for the laparoscopic approach compared to an open liver resection. 2 studies looked at non-R0 resection rates and no differences were found. So as previously mentioned, there is a discrepancy in the definitions of obesity between the East and the West. At the same BMI, there is a higher body fat percentage in an Asian patient with a higher ratio of intraperitoneal versus subcutaneous fat. This could translate to a more difficult operation or exposure in a laparoscopic liver resection. In addition, morbidity and mortality that is associated with obesity manifests at lower BMI levels in Asian patients, and this is the reason for the differences in WHO definitions of obesity. Another thing to consider is that in Western populations, there is often more patients at the extremes of BMI. For example, here in Australia, we see many patients with BMIs of greater than 35, 40, or even more than that. And these patients have not been studied in these papers included in our systematic review. The other thing to consider is that the benefits of the laparoscopic technique could actually be more pronounced in an obese patient. The laparoscopic technique allows a better view and exposure in a wide and deep abdomen, and often in an obese patient, there is a thick layer of subcutaneous fat, which is difficult to retract in the open method. This is supported by the fact that there was no increased blood loss or transfusion in obese patients in this systematic review, and only one study found an increase in conversion rates. The limitations of the study include a low number of included studies, which were all non-randomized, single-center, and retrospective. Many of the authors in the included papers mentioned selection bias, where easier cases and tumors in more favorable positions, as well as more minor hepatectomies, would have been chosen for the laparoscopic approach in obese patients. Overall, there was also a low number of obese patients in this systematic review, especially those at the higher extremes of BMI. In conclusion, current evidence is sparse, but it does show that laparoscopic liver resection is feasible and safe in obese patients within the limits of careful tumor and patient selection. More research is required to examine the effects of obesity on surgical and oncological outcomes after laparoscopic liver resection. This is particularly pertinent in Western populations and those at the upper extremes of BMI. Thank you for listening.